I will be rationalising the safety and effectiveness of diabetes medication as a weight loss drug within the scope of obesity and type 2 diabetes mellitus. Obesity is defined by the World Health Organization as abnormal or excessive fat that accumulates and presents a risk to health. Being overweight or obese are defined by measures of body mass index. The WHO defines overweight as a BMI of 25 to 29.9 kilograms per meter square and obesity as over 30 kilograms per meter square. The World Health Organization describes obesity as a global pandemic and reported in 2022 that 1 in 8 people worldwide were living with obesity. That since 1990, adult obesity had more than doubled and adolescent obesity had quadrupled since then. The number is predicted by the World Health Organization to further increase by 167 million people by 2025. Obesity is a risk factor for various diseases. Studies during the recent COVID-19 pandemic showed people with obesity had higher levels of hospitalization, intensive care unit admissions, and death. The common pathophysiological pathway in comorbid conditions of obesity, such as type 2 diabetes, is the fact that obesity develops when there is an imbalance between caloric intake and energy use. When there is excess energy intake, the excess energy is stored as fat and glycogen in subcutaneous adipose tissue and organs. The excessive adipose tissue is known to secrete inflammatory cytokines. In non-obese individuals, there is a balance between the secretion of pro-inflammatory cytokines and anti-inflammatory cytokines secreted by adipose tissue. But when there is weight gain and excess adipose tissue, an imbalance between the two occurs, with more pro-inflammatory cytokines being produced, known as adipokines. Over time, with the increased pro-inflammatory cytokines released by adipose tissue, a low-grade chronic inflammatory state occurs with increased infiltration by circulating macrophages and progressing to metabolic syndrome, a metabolic disorder resulting from obesity, manifesting in glucose intolerance, insulin resistance, central obesity, dyslipidemia, hypertension, and other risk factors for coronary vascular disease. Obesity results in an increase of free fatty acids circulating the blood, causing an increase in vascular endothelial growth factor A and vimentin. This is implicated in tumor initiation and tumor growth, insulin resistance, and steatosis in the liver. Obesity is also implicated in an excess of tumor necrosis factor alpha and leptin, which results in inhibition of insulin receptor activation, manifesting with insulin resistance in muscle, liver, pancreatic islet cells, and adipose tissue, ultimately leading to type 2 diabetes. Finally, obesity can cause lipid accumulation in non-adipose tissues such as the liver, muscle, pancreas, epicardial, and perivascular tissues. The buildup of lipid in epicardial adipose tissue and perivascular adipose tissue causes a lack of oxygen to the end organs, resulting in dysfunction of the cells in these organs, followed by macrophage infiltration and further inflammation, which over time results in coronary vascular disease. Significant changes may result in a diverse number of chronic conditions, but I shall focus on the impact of obesity on type 2 diabetes, as up to 1/3 of obese people develop type 2 diabetes, and adults with a BMI greater than 35 kilograms per meter square are 20 times more likely to develop diabetes. Type 2 diabetes is rapidly becoming a significant health challenge, both in developing and developed countries. In 2020, diabetic treatment was the single highest area of health system spending at a cost of $952.7 million in that period, according to AIHW 2023. The cause of these astronomical costs are as a result of the long-term impact of diabetes, and in particular, the physical health burden of complications on the individual. Semaglutide belongs to a class of medications known as glucagon-like peptide-1 receptor agonists, GLP-1. By semaglutide activating GLP-1 receptors, there is augmentation of insulin secretion, which is glucose-dependent, inhibition of glucagon release, and suppression of hepatic gluconeogenesis, which reduces both fasting and postprandial glucose levels. Semaglutide improves the efficiency of pancreatic B-cell functioning and thereby augments the production of insulin. Semaglutide has also been shown to improve insulin sensitivity, believed to be due to reduction in body weight. Semaglutide causes a delay in gastric motility, promoting the sensation of fullness. The safety and efficacy of semaglutide use for obese non-diabetics was proven in the semaglutide treatment effect in people with obesity clinical trial program, also known as STEP. During the STEP 5 trial, it involved giving once-weekly subcutaneous semaglutide 2.4 milligrams and assessed against placebo. Of the 152 participants in the semaglutide group, 12 reported serious adverse events, and out of the 152 participants in the placebo group, 18 reported serious adverse events. Results found the average change in body weight from baseline to week 104 was minus 15.2% in the semaglutide group versus minus 2.6% with the placebo group. In conclusion, I would argue that the growing body of data from the STEP clinical trial program has demonstrated the efficacy and tolerability of once-weekly subcutaneous semaglutide in individuals with overweight or obesity. The STEP trial consistently showed mean weight losses of 14.9% to 17.4% in people who did not have diagnosis of diabetes. They also showed improvements in cardiac risk factors, metabolic risk factors, physical function, and quality of life. I therefore believe that it is not harmful to use diabetes medication as a weight loss drug, but rather that it is safe and helpful. I also believe that by using such medications to tackle the prevalence of obesity leading to type 2 diabetes will result in significant cost savings to the public purse through early disease prevention,